Welcome to this deep dive on craniosynostosis. This is really key information for surgical trainees, especially if you're preparing for board exams like the FRCS. We're aiming for a direct, concise review of the core concepts.
Exactly. We'll hit the definition, incidence, the normal physiology of cranial growth and suture fusion, touch on etiologic factors, genetics,
Right, and then indications for treatment, diagnosis, the different classifications.
the diddle-me-topic, coronal, lambdoid, yeah.
Oh,
And importantly, how to differentiate from deformational plagiocephaly, plus the main syndromic types, and finally, treatment principles.
great. Let's start with the basics then. Normal cranial growth, how does the skull typically develop in infants and young children?
Okay, so cranial growth is primarily driven by the brain expanding and also the cerebrospinal fluid volume increasing. The brain itself grows incredibly fast early on.
How fast are we talking?
Well, it triples in size by 1 year, quadruples by 2 years. By age 3, it's already about 85% of its adult size, and it's nearly adult size by, say, 6 to 10 years old.
And the skull keeps pace through which mechanisms?
Two main ways. First, there's sutural growth, that's bone being laid down right at the suture edges, perpendicular to the suture line. Second is appositional growth, which is more about remodeling bone gets resorbed on the inner surface of the skull and deposited on the outer surface.
Okay. And the sutures themselves, when do they normally fuse? This is crucial for spotting abnormalities.
Absolutely. So the metopic suture, the one down the forehead, that's the first, usually between 6 and 8 months.
6 to 8 months, got it.
Then there's a big gap. The sagittal suture doesn't typically fuse until around 22 years. The coronal's around 24 years, and the lambdoid's around 26 years.
So well into adulthood for most of them, and the
The
fontanelles.
soft spots, yeah.
Ah.
The posterior fontanelle usually closes between 3 and 6 months. The anterior fontanelle, the larger one on top, typically closes between 9 and 12 months. So you really need to have these timelines in mind.
Definitely. So when that normal sequence gets disrupted, when a suture fuses prematurely, what's going on? What are the theories?
Well, the guiding principle is Virchow's law. Basically, if a suture fuses too early, skull growth is restricted perpendicular to that suture line.
And it compensates.
Exactly. It compensates by growing parallel to the fused suture, leading to those characteristic head shapes. As for why it fuses early, there are a few theories.
Right.
One involves the cranial base. The idea is abnormal tension transmitted through the dura mater, though that doesn't perfectly explain isolated suture fusion.
Okay. What else?
Another focuses on the suture's intrinsic biology. The dura mater itself has osteoinductive properties. It contains cells that can promote bone formation, potentially triggering early closure.
And then there are external factors.
Yes, extrinsic factors too. Things like compression in utero, possible ischemic events, maybe after hydrocephalus decompression, even abnormal brain growth like in microcephaly, or systemic issues like hypothyroidism or rickets can play a role.
Right. And what about the genetic component? How often is it inherited?
Genetics are definitely a factor. Current estimates are around 21% of cases have a genetic basis. This can include chromosomal abnormalities or, more commonly, single-gene mutations.
Which genes are typically involved?
We often see mutations in genes like FGFR2, that's fibroblast growth factor receptor 2, also FGFR3, TWISP1, and EFNB1. These account for a large portion of the known genetic causes.
Interesting. And is most craniosynostosis syndromic or non-syndromic?
The majority, about 2/3, is non-syndromic, meaning it occurs in isolation. The rest, maybe around a third if you include other associated syndromes, have craniosynostosis as part of a broader genetic syndrome. The specific gene mutations are found in varying proportions depending on the type of synostosis, like multi-suture versus single suture.
Okay. So when we diagnose craniosynostosis, what tells us treatment is necessary? What are the main indications?
There are really two primary reasons to intervene surgically. First, and most importantly, is to prevent or treat elevated intracranial pressure, ICP.
Right, the pressure inside the skull.
Exactly. Early fusion, especially of multiple sutures, can restrict brain growth and lead to this cephalocranial disproportion, pushing ICP above, say, 15 millimeters of mercury.
And the second reason?
The second is to address the skull deformity itself, primarily for psychosocial reasons, to allow for more normal social interactions as the child grows.
Are there other factors that can cause high ICP, especially in syndromic cases?
Yes, in syndromic craniosynostosis, elevated ICP can also result from things like intracranial venous congestion, hydrocephalus, or even upper airway obstruction affecting venous return. There's a clear correlation. The more sutures fused, the higher the risk of elevated ICP.
What sort of percentages are we talking about?
It's estimated around 13% with isolated single suture synostosis might have elevated ICP, but that jumps to over 40%, maybe 42% in non-syndromic cases with multiple sutures involved. And it's even higher in many syndromes.
So what clinical signs should make you suspect elevated ICP, especially in young children where it might be subtle?
You need to be vigilant for things like morning headaches, persistent irritability, recurrent vomiting, especially without other illness difficulty sleeping, any cognitive impairment or slip in developmental milestones.
Visual signs, too.
Yes, optic atrophy or documented vision loss are serious signs. And obviously, directly measured elevated ICP confirms it. You should also be aware of Chiari malformations.
Where the cerebellum herniates down.
That's right, downward displacement of the cerebellar tonsils because the posterior fossa is too small. This is quite common in syndromes like Cruzon and Pfeiffer, and it can cause non-communicating hydrocephalus, further increasing pressure.
And does the number of fused sutures correlate with developmental outcomes?
Yes, there's generally correlation between more extensive suture involvement and a higher risk of neurodevelopmental injury or impairment.
Okay, let's shift to diagnosis and evaluation. How do you approach it?
It always starts with a thorough history and a careful physical examination. You're feeling for lack of movement at the suture lines, maybe a palpable ridge over the fused suture.
Any visual clues on exam?
Definitely. Bulging fontanelles, sometimes called the volcano sign. You need to carefully assess the overall cranial morphology, looking for those predictable shapes we'll discuss. Also check the relationship of the orbital rims to the cornea, and look for any facial asymmetry or abnormal features.
What about measuring ICP directly?
Direct intraparenchymal monitoring is technically the gold standard, but it's invasive. And honestly, there's no universal consensus on exactly when to monitor, how often, for how long, or even what constitutes normal ICP values in young children. It's complex.
Are plain X-rays still used?
They can be useful sometimes. Standard views like AP, lateral, and Townes might show features like the harlequin sign in coronal synostosis on an AP view, which is that characteristic upswept orbital rim. You might also see thumbprinting or copper beading on the interskull table, but that's not very specific for high ICP.
What about looking at the eyes?
Fundoscopy is important to check for a papilledema swelling of the optic disc. It has high specificity for elevated ICP across all ages, but its sensitivity can be lower, particularly in younger infants.
Are there non-invasive ways to assess for pressure effects?
Transorbital ultrasound is emerging as a tool to measure the optic nerve sheath diameter. An increased diameter can suggest higher pressure. Visual evoked potentials, or VEPs, can also be helpful. Prolonged latency might correlate with axonal injury from sustained elevated ICP.
And imaging, CT, MRI.
CT scans are very commonly used, especially for preoperative planning. 3D reconstructions are invaluable for visualizing the fused sutures, understanding the morphology, and even calculating intracranial volume. In syndromic cases, CT is pretty much routine to look for hydrocephalus, Chiari malformations, or other associated bone or brain abnormalities.
When would you use MRI?
MRI isn't usually needed for isolated synostosis diagnosis. It's more reserved for select syndromic cases like Apert or Pfeiffer, where you might be concerned about specific issues like venous drainage pathways or other central nervous system pathology.
Okay, let's get into the classification based on which suture is fused. Can you walk us through the main non-syndromic types?
Sure. The most common is sagittal synostosis, making up maybe 40 to 50% of cases. This causes scaphocephaly or dolichocephaly,
Meaning?
meaning a long, narrow head, increased anteroposterior AP diameter, decreased width between the parietal bones. Often you see frontal bossing and some occipital coning or pointing at the back. It's much more common in males, about a 4.1 ratio.
Sagittal escaphocephaly. Next.
Metopic synostosis. That's the second most common, maybe 23 to 28%. This suture runs down the forehead. Fusion causes trigonocephaly, a triangular-shaped forehead, like the keel of a boat. You see bitemporal narrowing, sometimes hypotelorism, eyes close together, and often bilateral supraorbital retrusion.
Any specific signs on imaging?
Yeah, intracranially you might see the omega sign shape of the anterior fossa. The anterior cranial base often has an increased AP dimension. ICP elevation occurs in maybe 4 to 10% of these cases.
Right, then unilateral coronal synostosis.
That accounts for maybe 13 to 20% of isolated cases. This leads to anterior plagiocephaly, an asymmetric flattening of the forehead on the affected side, with compensatory bulging of the forehead on the opposite side.
What other features?
You get ipsilateral same-side flattening of the occipitoparietal region too, and often a bulge in the temporal fossa on that side. The orbit on the affected side looks recessed, particularly the supraorbital rim, and you might see that harlequin deformity on X-ray or CT. The nasal root often deviates towards the affected side, and the chin points away contralaterally.
Okay, that's unilateral coronal. What about bilateral?
Bilateral coronal synostosis is less common in isolation, maybe 5 to 10%, though many cases are familial. This causes brachycephaly,
Which looks like...
a broad, flat forehead. The suborbital ridges are recessed, the forehead might bulge upwards, and the skull base is wide but short in the AP dimension.
And finally, lambdoid synostosis.
This one's quite rare, less than 3% of cases. It involves the sutures at the back of the head and causes posterior or occipital plagiocephaly. You see flattening of the occiput on the affected side, often with a bulge near the mastoid bone on that same side. The skull base might slant downwards posteriorly on the affected side. Facial asymmetry can occur, but is variable. Bilateral lambdoid synostosis is extremely rare in non-syndromic cases.
That brings up an important point differentiating true lambdoid synostosis from deformational plagiocephaly, which is much more common.
Absolutely critical distinction. Deformational plagiocephaly, sometimes called positional plagiocephaly, affects maybe 1 in 300 infants. Crucially, it does not involve suture fusion and has no functional consequences like elevated ICP.
So how do you tell them apart clinically?
There are key differentiating features. In deformational plagiocephaly, the ipsilateral occiput is flat, but the ipsilateral forehead is typically bossed or pushed forward, and the ear on that same side is displaced anteriorly. This creates a parallelogram shape when viewed from above.
Whereas in lambdoid synostosis,
In lambdoid synostosis, the ipsilateral occiput is flat, but the ipsilateral forehead is often normal or even slightly recessed, and the ear on that side is typically displaced posteriorly and maybe inferiorly. There's often that ipsilateral mastoid bulge too.
got it. So parallelogram shape and anterior ear suggest deformational. What causes deformational plagiocephaly?
It's usually external forces acting on the malleable infant skull.
Yeah.
Supine sleeping position, which is recommended for SIAD's prevention, is a major factor. Torticollis tight neck muscles causing the head to turn preferentially to one side is another common association. Sometimes vertebral issues or even visual field deficits can contribute.
Okay. Are there any other, perhaps less common head shapes we should know?
Yes, a few morphologic variants. Pterocephaly refers to a tall, tower-like skull, often resulting from untreated or inadequately treated bilateral coronal synostosis, brachycephaly. Octocephaly describes a pointed head shape, sometimes seen with pansynostosis, where multiple or all sutures fuse early. And then there's Kleeblattschädel, the cloverleaf skull, a severe form where pretty much all sutures fuse prematurely except the squamosal sutures, leading to bulging in the temporal regions, usually associated with severe syndromes.
Right, let's move on to those syndromes. Can you highlight the key features of the most common ones associated with craniosynostosis, starting with Crouzon?
Crouzon syndrome is the most common syndromic form, maybe 1 in 25,000 births. It's autosomal dominant, usually caused by FGFR2 mutations, but with variable expression.
Clinically, what stands out?
Often bicoronal synostosis is present, but other sutures can be involved. Key features include exorbitism, bulging eyes due to shallow orbits, and midface hypoplasia. They often have a class 3 malocclusion with an anterior open bite. Hydrocephalus and elevated ICP are common, maybe in 65% of cases, and Chiari malformations are also frequent, maybe over 70%. Importantly, they typically do not have significant limb anomalies.
Okay, Crouzon. FGFR2, bicoronal exorbitism, midface hypoplasia, no major limb issues. What about Apert syndrome?
Apert syndrome is rarer, maybe 1 in 100,000 or more, also autosomal dominant, mostly sporadic mutations, usually FGFR2 again.
And the features?
They almost always have bicoronal synostosis, leading to a turbobrachycephalic shape, tall and wide head. They often have an enlarged anterior fontanelle initially. Exorbitism is present, often with downslanting palpebral fissures. The midface hypoplasia is typically more severe than in Crouzon, sometimes described as a parrot beak nose.
And the defining feature?
The defining feature is complex syndactyly fusion of the bones and soft tissues of both the hands and feet. It's often described as mitten hands and sock feet. ICP elevation is very common, maybe over 80%, often developing around 18 months. Intelligence can be variable. Acne is also common in adolescence.
Got it. Apert. FGFR2, bicoronal, severe midface, complex syndactyly. Next, Pfeiffer syndrome.
Pfeiffer syndrome, incidence around 1 in 100,000. Also autosomal dominant, can be caused by mutations in FGFR2, which tend to be more severe forms, or FGFR1, often less severe and more Crouzon-like.
Key characteristics.
Again, often bicoronal synostosis leading to turbobrachycephaly, Shallow orbits, exorbitism, hypertelorism, downslanting, palpable fissures are common. Midface hypoplasia is present, potentially causing airway issues. Hydrocephalus and Chiari malformations are risks.
And the defining limb finding.
The defining feature here is broad thumbs and broad great toes, hallucis. They might also have some mild syndactyly, usually cutaneous. Mental status is often normal in milder types, type 1 based on Cohen's classification, but severe forms, types 2 and 3, have poorer prognosis, often needing tracheostomy for airway obstruction.
Pfeiffer, FGFR12, bicoronal, midface, broad thumb stows. What about C3 Chotson?
C3 Chotson is more common, maybe 1 in 25,000 to 50,000. Autosomal dominant, caused by mutations in the TWIS1 gene, again, variable expression.
Features.
Mental status is usually normal. The synostosis pattern is often coronal, either bilateral, causing an asymmetrical brachycephaly, or unilateral. A low frontal hairline is characteristic, as is ptosis, droopy eyelids. They might have ear abnormalities like a prominent crociolysis. Facial asymmetry and a deviated nasal septum are common. Midface hypoplasia is less common or severe than in Cruzon or Appert.
Any limb findings?
Partial cutaneous syndactyly, usually of the second and third fingers or toes, can be seen. Short stature is also possible. Importantly, they have a risk of developing elevated ICP later, even after initial surgery, so follow-up is key. Reoperation rates can be high.
C3 Chotson, TWIS1, often coronal asymmetric, low hairline, ptosis, possible partial syndactyly. Lastly, Muenke syndrome.
Muenke syndrome might be more common than we used to think, possibly accounting for up to 10% of cases previously labeled as non-syndromic coronal synostosis. Incidence might be around 1 in 10,000.
Genetics?
It's caused by a specific point mutation, Pro250ARG, in the FGFR3 gene, autosomal dominant, but again, highly variable expression even within families.
Clinical picture.
Developmental delay is possible. Coronal synostosis is the most common cranial finding, but there's an interesting sexual dimorphism. Females more often have bicoronal, males more often unicoronal. Midface hypoplasia is uncommon. A subtle finding can be thimble-like middle phalanges in the hands. Bilateral sensorineural hearing loss is also associated. Generally fewer extracranial features than the other syndromes we've discussed, but like C3 Chotson, reoperation for elevated ICP can be needed.
Muenke. FGFR3, specific mutation. Coronal sex difference, possible hearing loss, maybe thimble phalanges. Okay, that covers the main syndromes well. Let's turn to treatment principles. How is it managed?
Fundamentally, it requires a multidisciplinary team approach. You need craniofacial surgeons, neurosurgeons, pediatricians, geneticists, ophthalmologists, orthodontists, speech therapists, psychologists, the whole team.
And the goals of surgery?
The main goals are 1, to expand the intracranial volume to allow for normal brain growth and reduce the risk of elevated ICP, and 2, to normalize the head shape and facial appearance for functional and psychosocial reasons.
What about timing? When do you typically operate?
Timing is definitely a point of discussion and can be controversial. The approach often differs between non-syndromic and syndromic cases.
How so?
Syndromic cases generally have a higher risk of elevated ICP, often require multiple procedures over time, and sometimes have intrinsically reduced growth potential. So intervention might need to be earlier or staged differently. Non-syndromic single suture cases might often be managed with a single open vault procedure.
Is there a general age window?
Generally, surgeries often performed between 6 months and 1 year of age. Operating earlier, say before 6 months, especially for pansynostosis or clear evidence of elevated ICP, might be necessary. But very early surgery carries risks, particularly significant blood loss in tiny infants.
What are the pros and cons of operating earlier versus later?
Early surgery, say 6 to 12 months, takes advantage of the bone being more malleable, easier to reshape. There's less compensatory deformity to correct, and the bone has greater potential for spontaneous healing and remodeling. The downside is that significant growth still remains, so there's a higher risk of recurrence or needing further procedures later.
And operating later, after 12 months.
Later surgery means the bones are stronger, which allows for more rigid fixation. More skull growth has already occurred, so maybe less risk of recurrence. But the bone is harder to shape, there's less spontaneous healing, and you often have more significant compensatory deformities that need to be addressed.
Let's focus on the syndromic cases first, as they often need a more complex, staged approach. What's a typical timeline?
It varies hugely, but a general pattern might be, if urgent decompression is needed for severe ICP, that could happen very early, under 3 months. Then suture release, cranial vault remodeling, maybe orbital reshaping often happens between 4 and 12 months. Sometimes posterior vault expansion is done first.
What about the midface?
Midface advancement, like a Lefort III osteotomy, is usually delayed until later childhood, perhaps 6 to 12 years old, when the facial skeleton is more developed and dental eruption is further along. Then, final orthognathic surgery to correct the bite, maybe a Laforte or mandibular surgery, happens in adolescence, around 14 to 18 years, often coordinated with orthodontics.
You mentioned posterior vault expansion as potentially being done first in the first year. How is that typically done?
Posterior cranial vault remodeling or expansion can be done through an open approach or increasingly using distraction osteogenesis.
What's the advantage of distraction?
Distraction allows for potentially larger expansions than a single-stage open procedure, might reduce the need for large bone grafts, and could potentially lead to more stable long-term results. The downside is it requires a second surgery to remove the distractors and involves a period of active distraction managed by the parents.
Can you briefly describe the posterior distraction technique?
Sure, the patient is usually positioned prone. A coronal incision is made, a posterior craniotomy is performed, often creating several strips or barrel staves of bone. Distractors, mechanical devices that slowly pull bone segments apart, are fixed across the osteotomy sites. After a latency period, the distractors are turned daily, usually about 1 millimeter per day, over several weeks to achieve the desired expansion. Then there's a consolidation period for the new bone to form in the gap, followed by removal of the hardware.
Okay. And frontoorbital advancement, FOA. When is that done and what does it involve?
FOA is often done after posterior vault expansion, or as the primary procedure in cases like bilateral coronal synostosis. The goal is to advance the forehead and upper orbits to protect the eyes, increase intracranial volume anteriorly, and improve appearance. It involves a coronal incision again. A frontal craniotomy is performed to remove the frontal bone flap, which is reshaped. A separate bandeau of the bone, including the supraorbital rims, is harvested, reshaped, and advanced forward. It's then fixed in its new position, often using bone grafts for support and absorbable plates and screws. Some degree of overcorrection is often aimed for, anticipating future growth. Bone grafts are also used to fill any remaining defects.
Post-operative care must be intensive.
Yes, usually requires ICU monitoring initially, careful fluid management, monitoring for bleeding, potential need for blood transfusion. Parents need clear guidance, especially if distraction devices are used. Complications can include bleeding, venous air embolism, a risk with cranial surgery, infection, CSF leak, or hardware issues.
Now, shifting to the mid-face surgery later in childhood, the Lefort third, you mentioned timing controversy.
Yes, there's debate about whether to do it earlier for psychosocial benefits versus later when facial growth is more complete, potentially reducing the need for repeat procedures. Distraction osteogenesis is often preferred now for Lefort III advancements as it may allow for greater movement and potentially better soft tissue adaptation.
Are there variations like monoblock or facial bipartition?
Yes, a monoblock advancement brings the forehead and mid-face forward together in one unit. Facial bipartition involves splitting the mid-face vertically down the midline, often used to correct hypertelorism or severe V-shaped maxillary arch collapse seen in some syndromes. The main goals are achieving better eye protection, improving airway, correcting the bite, moving towards a class eye occlusion, and providing better cheekbone projection.
And the final stage in adolescence adulthood.
That's typically orthognathic surgery, often a Lefort eye osteotomy, to position the maxilla correctly. Sometimes combined with mandibular surgery, like a bilateral sagittal split osteotomy, and maybe a genioplasty for chin position. This requires close collaboration with orthodontists. Facial contouring with grafts or implants might also be done to address any residual irregularities.
Okay, that's a comprehensive overview of syndromic management. Now, what about techniques for the non-syndromic types? Let's start with scaphocephaly, sagittal synostosis.
For scaphocephaly, several options exist. Minimally invasive techniques like endoscopic-assisted strip craniectomy, usually done very early, for example 3 to 4 months, followed by helmet therapy, are popular. Spring-assisted cranioplasty is another option, involving a craniectomy and placement of springs to gradually expand the skull, also done early.
And open procedures?
Open cranial vault reconstruction is the traditional approach, often done a bit later, for example 6-12 months. This can involve various patterns like reconstructing just the posterior vault, doing a total vault remodel, or specific techniques like the clamshell or pie procedure, aiming to increase width and shorten the AP length.
What about plagiocephaly and brachycephaly from coronal synostosis?
For unilateral or bilateral coronal synostosis, the mainstay is typically frontoorbital advancement, FOA, as we discussed. This involves a bifrontal craniotomy, advancing the supraorbital bar, endo, and reshaping the frontal bones to correct the flattening and asymmetry or the brachycephalic shape. Barrel saves might be used in the parietal regions too.
And trigonocephaly from metopic synostosis.
Treatment aims to widen the bitemporal distance and round out the forehead. This usually involves a bifrontal craniotomy, reshaping and advancing the supraorbital bar, often with an interposition bone graft in the midline to hold the expansion. Lateral canthal advancements might also be incorporated. Sometimes wedge osteotomies are needed in the temporal bone.
Finally, the rare lambdoid synostosis.
This requires posterior vault remodeling. Techniques often involve biparieto-occipital craniotomies, potentially switching the flattened occipital bone segment with the more bulging contralateral side and contouring the bone to achieve symmetry.
Just briefly, what's used for fixation and filling defects?
Fixation has evolved from wires to titanium plate screws, but now absorbable plates and screws made of polylactic glycolic acid copolymers are most commonly used in infants as they gradually dissolve over time. For filling bone defects or contouring, autologous bone grafts are preferred. Split calvarial bone from the craniotomy site itself is common, or sometimes split rib or iliac crest grafts. Particulate bone dust can also be used. Alloplastic materials like methyl methacrylate or hydroxyapatite cements are generally avoided in primary reconstructions in young children, but might be used for secondary contouring later.
Excellent. So, to quickly recap the key non-syndromic morphologies for exam purposes, sagittal gives you scaphocephaly long and narrow. Metopic gives trigonocephaly triangular forehead. Unicoronal causes anterior plagiocephaly ipsilateral frontal flattening. Bicoronal causes brachycephaly wide and flat forehead. And lambdoid causes posterior plagiocephaly ipsilateral occipital flattening.
Precisely. And remember, deformational plagiocephaly typically presents as a parallelogram with an anteriorly displaced ear on the flat side.
And for the syndromes, Cruzon think midface hypoplasia but no major limb issues. Appert add severe syndactyly. Pfeiffer think broad thumbs and toes. Sather-Chotson often asymmetrical coronal, low hairline, maybe partial syndactyly. Moignet-specific FGFR3 mutation, coronal involvement, maybe hearing loss.
That's a good rapid summary. It really underscores that managing craniosynostosis effectively demands a really thorough understanding of the specific type, the underlying pathophysiology, whether it's isolated or part of a syndrome, and the tailored treatment options available.
Absolutely. There's clearly a huge amount of detail in the surgical techniques and long-term outcomes that warrants further study. This has been a really valuable overview.